All right, so this is all about saving women's lives and the progress that we have made in doing so. So I would love for each of you to share how the approach to breast cancer, whether it's before diagnosis or after diagnosis, has changed in really important and impactful ways in just the last couple of years. And Dr. Aliabadi, I'll start with you.
I would say the technology is changing. We're getting better and better at diagnosing patients. Earlier, we have now 3D imaging that has artificial intelligence with it. A lot of centers in Los Angeles have that capacity. So when you're scheduling your mammogram, especially if you have dense breasts, 50% of women have dense breast tissue. If you have dense breast tissue, then you want to go for a 3D mammogram because a 2D mammogram will miss your lesion. So, we've gotten better at that. We have now blood biopsies. There are newer technologies. They're not as good as diagnosing breast cancer, but there's a test like Gallery that a lot of people do. The detection for breast cancer is low, but every year it's getting better and better. We calculate lifetime risk of breast cancer. That's been my dream. If you know your lifetime risk of breast cancer, then you can add ultrasound and MRI, and we're going to go through all of that. But the technology has gotten better, and and the treatment for it has also advanced. So overall, we're on the right path.
Incredible. Can you clarify 3D mammogram versus 2D mammogram? Because I don't know that. I always do a mammogram and an ultrasound, asking for myself. And I'm curious about the difference between that, and is a 3D mammogram the way to go?
Yes. So for patients who do not have dense breast tissue, it's okay to have a 2D mammogram. 2D mammogram is an X-ray, so they basically take a two-dimensional X-ray of your breast. For patients with dense breasts, which is 50% of us, when the radiologist looks at a 2D mammogram, half of it is white. The dense areas are completely white. So he makes a comment, if you look at your 2D mammogram at the bottom, well, as much as I could see, I didn't see any cancer. So they always have that sentence added at the end of your mammograms. For patients with dense breasts, you have to ask your doctor for 3D. What is a 3D mammogram? Basically, imagine flipping the pages of a book. The radiologist can see page by page all the layers of your breast. So they're less likely to miss a lesion that usually they would have missed on 2D mammogram. But even with 3D mammogram, if you have dense breasts, you still need to go for an ultrasound. So for dense breast tissue, you ask for a 3D mammogram. It's covered by insurance. And if your mammogram report, you can't really touch your breast and say, I have dense breast tissue. Dense breast tissue is a mammogram finding or an MRI finding. So look at your MRI. If it says dense, ask for a 3D mammogram. And in addition to that, ask your doctor for a breast ultrasound.
Thank you for clarifying that. I hope everyone's taking notes. Great advice. Kristen, I know that you focus a lot on the storytelling and messaging around breast cancer. How has that shifted?
I mean, look at this room. We're having a conversation about breast cancer. And think about our moms and our grandmothers. They were not talking about breast cancer. They weren't bringing it up. They weren't talking about it at home. They weren't sharing if they had that experience. You didn't talk about it. And I think that's such an important sort of improvement, innovation where we are. The data that we're getting, the fact that we have more diagnostic tools means better treatments. It means better options for women with breast cancer. And knowing that breast cancer is not just one anymore. Now we know it's made up of multiple mutations, which my friend Dina is going to talk about. And then understanding if you are diagnosed with that type of a certain type of breast cancer, you may have an option available to you, or you may know what options not to explore because they wouldn't work for you. So overall conversation, I think the community, and I love that comment from the last panel of we need to have an open conversation in community, and I think this is a great forum and more of these needs to happen.
And I think part of the conversation that a lot of people are afraid to approach is this idea of genetic testing. In talking to Dina, who is a geneticist, I confess that I'm afraid to do genetic testing, and I think a lot of people are, right? Like we're more comfortable not knowing what we don't know. So Dina, why should we all be considering genetic testing?
So whenever I talk to patients about this, the anxiety that people have, usually around testing, stems from uncertainty and a lack of control. But when you do something like a genetic test or a risk assessment, it gives you so much control. So I can tell you that the vast majority of my patients they come in very nervous, but then once they have this information, they now have a plan to go forward, which gives them that control. And their anxiety is actually much less than what they assumed it would be. Or they find that maybe they don't have something that was running in the family, and then they actually can know that they're not at that same increased risk because a family member had it and they did not have it. So just giving you that information gives you a path forward, and that is so life-changing for so many people.
Yes, Dr.
Can I add something? So one of the biggest myths around breast cancer is I don't have it in my family, so I'm not going to get breast cancer. 85% of women who get breast cancer don't have a family history of it. Less than 5% have a genetic mutation. Now, if you have any family history of any cancers, I don't care if it's pancreatic, colon, ovary, uterus, breast, whatever it is, take a genetic test. These genetic tests are covered by insurance. If you don't have insurance, it's $249. It will save your life if you're one of those 5%. But 85% of us don't have it in our family. The chance of an average American woman getting breast cancer is 12.5%. That's just average. If you're tall, it goes up. If you have dense breasts, it goes up. If you have children after 30, it goes up. If you're overweight, it goes up. If you have family history, it goes up. So you have to add all this information into a formula to see what your personal individual lifetime risk is. I'm sitting here, I have no family history of any cancer, no gene mutations, I'm not overweight, I didn't do hormones, I didn't smoke, I don't do drugs, I don't drink alcohol. My lifetime risk was 37%. So it's important to know what this number is, and without it, you can't just, please don't tell me I don't need a mammogram because I don't have it in my family.
Yeah, and actually adding to that too, even people that do have genetic changes or variants that increase risk may not have a family history, because there's a lot of reasons we don't know our family histories, whether people didn't talk, you're adopted, you're donor conceived. And so I think that in genetics in particular, we're gonna get to the point where everyone is going to be offered genetic testing for multiple conditions at once, but we're not there yet. And so until we're there, it is up to you to advocate for yourself, to ask your physician, and like you said, out of pocket, $250, not thousands of dollars like what people said, and that is so worth every penny.
Yeah, the recurring theme throughout this entire day, no matter what topic we're discussing, is to speak up, to know your body, and to ask questions. We have to be proactive when it comes to our health. We cannot assume that just because the doctor says we're good, that we are, clear to go and we don't have to do any other work. So really advocating for yourself is key. And Kristen, I know that's a big part of the work that you do, is getting women to take that next step and see it as a sign of empowerment.
Yeah, we were talking earlier today about a commercial that I worked on for Super Bowl. Your Attention Please. It's a campaign that my company. I love it.
Can you just give a little synopsis of it? Because I think people will remember it.
So, working in breast cancer and working in therapeutics, one of the findings that was baffling to us is that 1 out of 2 women don't make their appointments for mammogram per year. When they should. Over 40, you should be going every year. And I'm one of them. I missed mine. I was busy. I have kids. I've got a life. I've got work. I'm just not going to make my appointment. I'll go next time. And that next time, it did show something. And to me, that was scary enough to go, okay, I got to go every single time. But 1 out of 2 of us are not going. And so this is a challenge. And that's our first line of defense, is a mammogram, is those screenings. So with this campaign that we developed, Your Attention Please, was to really kind of flip the narrative around breasts. And let's talk about them. We sexualize them. We think they're fantastic. We love to dress them up in different bras and lingerie. But when it comes to their health, we're like, eh. So we really wanted to make sure that we're thinking about that and flip that narrative and get women to go get those screenings. If you're over 40, schedule your mammogram. It's that first line of defense. If you're under 40, know what your risk factors are. Take that test. Talk to your doctor. Talk to Dr. A, find out what are my risk factors and why, and how should I be a little bit more vigilant about my disease.
We've talked a lot so far about the diagnostic phase. Let's say, however, you have gotten a diagnosis of breast cancer. Dr. Aliabadi, why is this not something that's as terrifying as maybe it was even 5 years ago?
First of all, that's a very good question. I always tell my patients, if you're going to pick one cancer to have in your lifetime, let it be breast cancer. We know how to diagnose it early as long as you show up for your imaging, and we know how to treat it for majority of the time. Unfortunately, because people don't know their lifetime risk, they're still getting diagnosed. Even at an early age, they show up at stage 4, so those are a little bit more complicated. But we even can cure stage 4 breast cancer. I had stage 1 breast cancer 6 years ago, and I'm sitting here cancer-free, and a lot of us, you guys, thank you. But it's, it's of all the cancers, we've gotten really, really good at not only operating on it, having good chemotherapy, we have immunotherapy right now, and we have long-term hormonal suppression for patients, even for patients who have high lifetime risk. And I want to take a minute, because I think it's the most important, talking about the lifetime risk. Is that okay?
Yes, absolutely.
Because it's so important. We can't talk about it enough. You need to know your lifetime risk of breast cancer. There's a Tyrer-Cuzick risk calculator. I want every single one of you to go home and do that test. If you don't have it, you can go on SheMD. I have it for free on the SheMD podcast. Just calculate your lifetime risk of breast cancer. If your lifetime risk of breast cancer is 15% or less, you fall into the low risk category, so you can start your mammogram at age 40 or 10 years before your first degree relative was diagnosed with breast cancer. And if you have dense breasts, you do ultrasound. But if your lifetime risk is 20% or more, you are not to wait until 40. You actually have to start your breast imaging as early as 30. And you alternate mammograms and ultrasound with an MRI. So these are young women who sometimes you hear on the news at 36, so-and-so had stage 4 breast cancer, is because she should have had her imaging at 30. And if you have any family history of breast cancer, then you start your genetic testing at 25, because if you do have BRCA, then you start your breast imaging as 25. So we can't just talk about the age 40 anymore. The age 40 is for low-risk women. A lot of us, you'd be surprised, half of us in this room will have lifetime risk above 20%, believe it or not. And you guys, who knows their lifetime risk of breast cancer here? If you know your first name, last name, date of birth, you need to know your lifetime risk of breast cancer.
Add that to the list. Dina, let's say that you conduct genetic testing on someone and their worst fear is realized and they realize that they have a higher risk of breast cancer or another kind of cancer. What is that conversation like in the room, and what options are available to someone in that situation?
Sure. So a lot of the genes that we're looking at are not just going to involve breast cancer. So there's other cancers, of course, and there are different ways to look for or lower the risk of a lot of these different cancers. So it really depends on the gene, which is why it's so important to see a provider that understands genetics and that can really explain the information to you, because it is so personalized. And we use your personal history, your family history, and the genetic information together to help you understand your risk for multiple cancers. So that discussion, as I kind of mentioned earlier, a lot of people are very surprised at how much almost a weight is lifted off their shoulders because they now have this information and a plan. And so what I do as a genetic counselor is sit with someone and help develop this medical care plan that then their healthcare providers can go through with. And again, it just gives people a sense of control and really lowers anxiety at that point.
Better to know.
Yeah, exactly. Knowledge is power, for real. It's totally power, yeah.
Kristen, I introduced this panel by talking about breast cancer as a disease that we have actually really made progress against, which we can't say about too many conditions in women's health. And I'd love to hear from you what you think has made the difference.
I think, again, data and having diagnostics where we didn't before. And again, these forums, having early interventions and diagnostic tools that are getting us to where we are today, and the additional data that are going to get us in the future. Conversations, I think that plays a big part. Having a physician that's willing to talk to you and to spend that time in the doctor's office to talk to you about your risk factors and talk about your health and what you should be thinking about. I mean, we've made inroads there. So thank you. Thank you for what you're doing, because really appreciate it. And more to come. And I think it's really interesting that there are other diseases that I think are now playing a similar role. Menopause. clearly is having a moment, and that's fantastic. Endometrial cancers and others are going to be having a greater moment now. More women's health is having a moment, and it's really nice to see that, and I think it's the inroads that breast cancer has made.
Can I answer that too? I also want to add that, my master's thesis was about using media to educate the public about genetics, and we actually, in the academic setting, there's something called the Angelina Jolie effect, because when she came out with her BRCA diagnosis, it created this ripple effect of women coming in and asking for testing. And so for everyone in this room that works in media, you are so powerful in getting these messages out there. For you who's working with people with big impact and big voices, it is so powerful to get their messages out there. So if you have a following, if you have an audience, and you have a story, sharing that story makes a huge impact on healthcare, on who gets funding, on how we talk about it, on how accepted it is. So for everyone in media, you are very powerful in this conversation.
Thank you for that. Dr. Aliabadi, what's next when it comes to breast cancer? What is kind of like in 10 years, what's going to be different? What are we going to be talking about on this stage when it comes to breast cancer?
Hopefully we're not talking about lifetime risk, because I think we still have a long ways to go. I think when you were talking about media and everything you guys are doing is empowering women. We heard it during the menopause talk too. You have to be your own health advocate in order to, because women get dismissed. 50% of women, when they go to the doctor, they come out, they're like, my symptoms were dismissed. My concerns were not addressed. So because of that reason, instead of going just to your appointment, empower yourself, educate yourself. Right now you can go on ChatGPT to get all the information. Be ready when you go to that appointment. I think in the next few years, the blood biopsy is going to be huge. Artificial intelligence, reading it. RadNet, when they first started incorporating artificial intelligence, within the first 6 months, AI detected 500 more lesions that the radiologist had missed. My breast cancer, my mammogram was negative, my ultrasound was negative, my breast MRI was negative. I begged my doctors to do a double mastectomy. They told me, you don't have family history, you don't have a gene mutation, you're not going to get breast cancer, but my lifetime risk was 37%. I begged them to remove it because I had 3 little kids at the time running around. They all called me crazy, paranoid, anxious, you name it. I finally found a doctor who did my double mastectomy, and a week later they told me I had breast cancer. So be your own health advocate. We're getting much, much better. I think the blood biopsy is improving, imaging is improving, artificial intelligence is improving, the treatment, immunotherapy is improving, and with artificial intelligence, we're going to be able to do targeted treatments. Eventually, what I think will happen 10 years from now, we're going to have 3D models of the cancer that they biopsy, and artificial intelligence with computing, what is the word? This is a new generation of computer. What is it, Kambiz? No. Vaccine is another one. But with the new generation of computers, it's not AI. It's beyond the AI.
Thank you for helping.
They will basically, you will basically make it 3D. Quantum computing. Thank you.
All right, winner, gold star.
I'm blanking on it. So what's going to happen? They're going to you can take a biopsy, you make a 3D model of it, you give it to the computer, and these computers will connect millions of data from around the world. So it's not just one computer connected to the other. And basically, they will have a treatment plan specific to that specific patient and that specific tumor. So individualized care will be the
Custom
future
care.
of medicine. Yeah.
Well, that's very exciting, and I hope it does come to fruition. Final question. What is one thing you want every woman in this room to take with her at the end of the day when it comes to how she thinks about breast cancer? Dina, I'll start with you.
I think your body is your body, and I'm sure this has been said all day, but you're going to be the person that cares the most and has the most stake in, what happens with it. And so, like Dr. Aliabadi said, she had to fight for what she knew was the right choice for her. And so I think when it comes to understanding your risk, the options that you have available to you, which are going to be very personal to each and every one of you, that knowing that you are the one that makes the decision. And if you're working with a provider that is not making you feel like you have options, that it's probably not the right provider for you.
That is something we cannot say often enough.
Yeah.
So thank you, Kristen.
That's a really good one. I'm not going to repeat that then. I'm just going to say agency over oneself, but information is power. So while you're advocating for yourself, go and get as educated as possible. Look for those tools that are out there and available to you. Don't miss your appointments. Go in, get your screenings. That's, again, it's your first line of defense. Too many women are still being diagnosed with breast cancer. And while if you can get it in earlier stages, there is a higher likelihood for cure, but in the later stages and metastatic, it's just an extension of time. And so while we will continue to do what we can in the labs, in research to really improve on the care, information is power. Arm yourselves with that information and go get screened.
Dr. A, we'll finish with you.
I'm going to repeat myself. Know your lifetime risk of breast cancer.
I think we got that.
If you have family history, do genetic testing. The genetic testing I use in my office is MyRisk, and I'll tell you why. One, it checks for 48 cancer-causing genes. BRCA is just 2 of those 48 cancer-causing genes. 2, it will calculate your tyrosine, which we talked about. 3, it looks for little DNA markers in your DNA that some women walk around with a few of them, others have a ton of those little markers. Those markers can push your lifetime risk up unrelated to the 48 cancer-causing genes. So for that reason, your tyrosine might be 20%, but if you have this calculation, it might jump to like 38%. Know that we have ways to reducing that risk. Number one, if your risk is above 30%, and you're done having children, you can take a medication called tamoxifen for 5 years. Taking a pill for once a day for 5 years will reduce your risk by 50%. So if you're at 40%, it'll bring you down to 20%. So that's one option. Second option for patients north of 40%, or if you have a genetic mutation like BRCA who can push you to 80% lifetime risk, you can consider doing a prophylactic double mastectomy and remove your breast tissue. And the third one is if your lifetime risk is 20% or more, just do mammogram, ultrasound, and alternate with MRI.
Yeah.
If you do this, I promise you're not going to end up to your doctor's office with stage 3-4 breast cancer. I promise you.
Yeah. I'm good. Oh, yeah. I'm going to add one more thing because that you just touched on. So a lot of people, when they had genetic testing more than 5 years ago, only had the two genes, BRCA1 and 2. And now we know that there are a handful of other genes, and we can get lots of genes tested at the same time. So if your testing is older than like 3 to 5 years old, it's worth checking in with the person that ordered it to make sure that your panel is up to date. Because that information, that genetic code doesn't change, but the genes on the panel and the way we interpret that can change. So again, keep on top of that with your provider.
Really incredible information that we do not get from that 7-minute doctor's visit normally. So thank you.
And you know what? I have a podcast. I just did it for women because I love women. And my mission is to save your lives. So go on SheMD podcast. We cover every topic from menopause to PCOS to endometriosis to breast cancer. Empower yourself and be your own health advocate.
What a great note to end on. Dina, Kristen, Dr. Aliabadi, thank you so much.